for strain and counter strain in the cervical spine. You need to palpate the cervical erector spinae, the trapezius, the levator scapulae, suboccipitals, a whole range of different muscles. Obviously, it's impossible to tell exactly which myofascial structure you're pressing on. So, you're just making a best estimate and working from there. So I try not to overthink the specifics of which muscle I'm on anatomically, although still making the best attempt. For instance, for the cervical erector spinae, their anatomical location is between the spinous process and then moving laterally towards the transverse process, essentially overlaying the articular pillars and facet joints in the lateral cervical spine. They're running from the upper thoracic spine and eventually attaching onto the occipital bone and obviously attaching onto the individual segments in between. When palpating, we need to work our way through the muscle at varying depths of tissue pressure, from relatively superficial to quite deep. I'm using the pad of my finger to palpate through that tissue, searching for tender spots. This technique involves a lot of communication with the patient, so it's essentially getting clear feedback from the patient on where they feel pain, tenderness, irritation. So when I do find a tender spot, for instance, let's say this part of the cervical spine, we then need to search for a position of greatest comfort and ease and passively bring the patient into that position without much active contraction of the muscle we're touching. So if I maintain a contact on that tender point, I apply pressure, testing it. Maybe even I could ask the patient to give a verbal analog scale for the amount of pain. So on a scale of 1 to 10, how much discomfort it's causing. I then maintain my contact but reduce the pressure, and I will move the C-spine to a position that might give some ease to that muscle. So generally this is a position that brings the origin and insertion of the muscle closer together, but it may involve lengthening the muscle as well. So essentially we have to test different things. So for instance, in the cervical erector spinae, typically for the left cervical erector spinae, this will involve left side bending, extension, and maybe some left or right rotation in order to find a position of ease. So I can gently bring the patient towards that position, maintaining my contact. When I'm in the new position, I then apply a stronger contact to reassess. Maybe I could ask for the verbal analog scale again, how much pain out of 1 to 10. And essentially looking for close to no pain at all. So we eventually find that specific position where when I retest, there's as little pain as possible. I then maintain the location, but I don't maintain the pressure, and keep the patient's head in that position, sustained in that position, as relaxed as possible for up to 90 seconds. So during this time, generally I'll encourage the patient to focus on their breathing, just take some relaxed breaths in and out. After that time period, when I move the patient's head back to the neutral position, it's essential they don't then contract the muscle again. So from here, maintaining the location but not maintaining any pressure, I explain to the patient, please keep your head as relaxed as possible as I move you back to the neutral position. You can also use the patient's breathing, so get them to take a deep breath in, and as they breathe out and maintain the relaxation, just bring them back to neutral. And I can then retest the same spot and get that verbal feedback for how much pain they feel. And this can be repeated any number of times for various tender points in the cervical erector spinae.